Assalamu alaikum. Hi everybody, my colleagues in electrophysiology and cardiology. Today we are going to continue module of 100 golden rules in supraventricular tachycardia. Today we will highlight the basic EB study. How can we perform regular step-by-step approach of electrophysiology study to differentiate between the nodal and the extranodal conduction to reach the diagnosis. We have differential diagnosis of supraventricular tachycardia. Is it atrial tach, AVNRT, accessory pathway mediated tachycardia? So let's start to know how can we differentiate between nodal conduction. In the left hand we can appreciate the conduction between ventricle and the atrium during ventricular pacing is only nodal conduction, so retrograde conduction done through the AV node. However, on the right hand we can appreciate ventricular pacing node, the conduction is done through accessory pathway. The impulse is conducted through the accessory pathway to reach the atrium. So let's go to our golden rules. First golden rule today we have is nodal conduction. How we know is it nodal conduction or not? In nodal conduction we will found antegrade conduction. Number one is decremental. The more atrial pacing, the longer AH or AV. Number two, it's a narrow complex, no evidence of pre-excitation, no evidence of delta wave. However, the retrograde conduction we can appreciate VA decrementation. The more incremental pacing, the more decrementation, longer VA interval. And regarding the atrial activation sequence, it will be concentric. So the earliest A will be at HIS or CS910. On the other side, extranodal conduction, it's a golden rule. We can appreciate antegrade conduction in accessory pathway, no evidence of decrementation. However, we can see pre-excited QRS complex, evidence of delta wave and ventricular pre-excitation because the conduction was through accessory pathway rather than AV node. And on the other side, retrograde conduction, we can appreciate no evidence of decrementation, and retrograde atrial activation is eccentric in case of lateral accessory pathway and concentric in case of septal accessory pathway. Let's go to the EB study. As we know, we will put RV catheter from which we will base, and we have HIS catheter, coronary sinus catheter, and high right atrium. Let's go to assess retrograde conduction when we base from RV to differentiate is it nodal or extranodal. Then go to antegrade conduction through basing from the atrium to differentiate between nodal and extranodal. As we know, when we do the basic standard EB study, ventricular burst pacing extra stimulus to see the antegrading extra stimulus to see the antegrade conduction. So let's see the antegrade and retrograde conduction. Start with ventricular burst pacing to assess retrograde conduction. Golden rule: when we start with incremental ventricular burst pacing, we should assess presence or absence of retrograde atrial activation to see rule in, rule out accessory pathway. Number two, retrograde atrial activation sequence, is it concentric or eccentric? Retrograde VA conduction, wink back to see there is decrementation or not. Number four, retrograde VA wink back cycle length. What does it mean? It's defined as cycle length where 1-to-1 retrograde conduction stop. So let's see this example. On the left side We start incremental ventricular pacing. We can appreciate in the left panel there is concentric activation. As it's a nodal conduction, we can see the more incremental pacing, there is decrementation and the VA time increase, and the earliest atrial activation and CS 910. On the right panel, it is extranodal conduction. How we know this? No evidence of decrementation. It's a fixed VA. However, the earliest atrial activation CS12. Now let's see the ventricular extrastimulus pacing to assess retrograde conduction. Golden rule: when we use the ventricular extrastimulus, we have to assess retrograde atrial activation, VA conduction, yes or no, to exclude accessory pathway. Number 2, retrograde atrial activation sequence, is it concentric or eccentric? Number 3, decremental retrograde VA conduction. Finally, retrograde VA refractory period and the ventricular refractory period. So what is the difference between the VA refractory period and the ventricular refractory period? To understand this concept, it's a golden rule. We have to know the VA effective refractory period is the longest time interval following a ventricular stimulus that failed to conduct to the atrium. On the other side, the ventricular ERB is the longest interval after ventricular action potential, during which the ventricular muscle is unable to generate a new action potential, no ventricular depolarization. It's just a spike without activation. So let's go to see some examples. In this example, we will give ventricular extrastimulus pacing, give S1 at 600, then give S2 the extrastimulus at coupling interval 400. Let's see, give the impulse, it will go retrograde conduction through the AV node, then atrium, and we can appreciate in the AGM 1-to-1 conduction, and the VA is very clear, the earliest retrograde A at the level of His, so looks concentric activation. Let's continue the study and give S2 at shorter coupling interval 360, where we can appreciate decrementation and the VA started to prolong. It's an evidence of retrograde nodal conduction. Continue the study, give S2 at coupling interval 260. We can appreciate more decrementation as a clear evidence of nodal conduction, decremental conduction. Then let's give S2 at 250. What happened? VA block. It's a VA effective refractory period, as we told before, spike, then ventricular depolarization, then no conduction through the AV node. Then let's give S2 at 230, very short coupling interval. We can appreciate only spike, no ventricular depolarization, what is called ventricular refractory period. Now let's go to next golden rule. When we give ventricular extrastimulus, from which in accessory pathway we can confirm the accessory pathway presence. Not only this, also we can know where is the accessory pathway. Is it right lateral accessory pathway, left lateral, anteroseptal, posteroseptal? And we can imagine when we put coronary sinus catheter, His catheter, and high right atrium, we can predict the presence of accessory pathway. For example, right lateral accessory pathway, the retrograde A, the earliest one, will be at high right atrium. Left lateral accessory pathway, we will find the earliest A, CS110. Anteroseptal accessory pathway, earliest A at the level of His, Posturoseptal accessory pathway, earliest A, CS 910. So let's go to some example. First one, we can see the ECG 1 to V1, then RV catheter, high right atrium, His and coronary sinus. Then we give S1, then S2, and we will ask where is the earliest retrograde A. In this example, we can appreciate at the channel of high right atrium. So we are dealing with right lateral accessory pathway. No doubt about this. Let's go to next example. When we give S2 and we find the earliest A at the level of distal coronary sinus, so it's a confirmation of left lateral accessory pathway. In this example, S2 and retrograde earliest atrial activation at His. So it's anteroceptal accessory pathway versus nodal conduction. How can we differentiate between this? We will know later. Last example, we give S2 and we can appreciate the earliest retrograde A at CS 910. So it's a concentric atrial activation sequence. Posturoseptal accessory pathway versus concentric nodal conduction. So let's go to this golden rule. When we have concentric retrograde activation with earliest retrograde A at CS 910 or His, so we are dealing with AV nodal conduction versus septal accessory pathway. Simple way to differentiate between them, is it decremental or non-decremental? Decremental conduction, no doubt it's a nodal, it's a AV node. But if there is no evidence of decrementation, we are dealing with septal accessory pathway. But there is another golden rule to differentiate between AV nodal conduction septal accessory pathway using a special advanced diagnostic maneuver like overdrive basing, his synchronous BVC in case of tachycardia, or using differential RV basing, para-Hessian basing if no tachycardia, and we will know more details about this later. Now let's go to another golden rule. When we use the ventricular extra stimulus, not only to confirm is it nodal or extranodal, but also to know where we base from. If you look at the retrograde activation sequence after the ventricular extra stimulus and you see the VA interval, we can know, do we base from RV base, mid-septum, RV apex, or there is evidence of right bundle branch block. So let's comment about retrograde activation sequence. Each activation ahead or after ventricular activation, and what about the VA interval? Let's go to the first example from which we base from RV base. We give ventricular extra stimulus. We can imagine if we base from this point A, RV base, and the impulse will go to ventricle to make ventricular activation. Then it will conduct down to reach the His-Purkinje system and the tip of right bundle branch. Then it will go retrograde through the His-Purkinje system to reach his AV node, then atrium. In this example, when we base from the RV base, we can appreciate the VA time is 110 milliseconds. Okay, let's go to next example. As we base from mid-septum, what happened? Surprisingly, the VA time is very short, 70 milliseconds, and each activation come ahead from the V. Why? Because actually the impulse, once it go from the RV catheter, it go direct to right bundle, then retrograde right bundle and his Purkinje system, and reach the his AV node and the atrium direct before the ventricular activation. That's why the H come ahead from V, and the VA time is very short because we are very close to the His-Purkinje system. Also, if we base from the RV apex, we can find the VA time is short, 90 millisecond. But in the last example, we can appreciate a surprise where when we base from the RV apex and we found there is evidence of right bundle block. So what happened? Transseptal conduction. The impulse go through the septum, reach LV to reach the left bundle branch and start a long way conduction, left bundle, then reach His and AV node atrium. That's why VA time is very long, about 110 millisecond. It's very long, and this is the summary in which we can imagine where do you base from and what about the VA interval. Let's tell the VA interval will become very long if we base from the base of the heart, VA interval in this example 110 millisecond, or when the evidence of right bundle block, the VA time will be very long because transseptal conduction, left side, left bundle branch block, retrograde conduction. And this is the summary. Now let's go to an amazing example when we give ventricular excess stimulus from mid-septum at coupling interval 460 millisecond. We can appreciate SC2 from RV catheter. H come very early and the VA interval is very short. Then give SC2 at shorter coupling interval 350 millisecond. What happened? VA interval become long and long because of decrementation, retrograde conduction through the AV node. Then what happened when we give the excess stimulus, short coupling interval 320 VA block? We reach the ERB, so it is V without A. Then after this we give excess stimulus at 290 shorter coupling interval. We can appreciate VA time prolonged more, H come late after V. Why? Because retrograde conduction was transseptal conduction, reach left side, then retrograde conduction through the left bundle, then His and the AV node. That's why the VA time prolonged and the H come late after V. Then after this, what happened? We give SC2 excess stimulus at 280 millisecond. What happened? Antegrade, recovery of right bundle branch block, so that the impulse can return down the initially blocked right bundle branch. It came down again through the right bundle, producing the QRS complex with typical left bundle pattern. And finally, we can appreciate SC2 as 260 millisecond. Now let's go to assess the antegrade conduction, atrial burst pacing, excess stimulus to differentiate nodal and extranodal conduction. Atrial burst pacing, incremental atrial burst pacing, golden rule to know that we have to assess is there any evidence of pre-excitation delta wave when we give incremental atrial burst pacing or not. Decremental AV nodal conduction in case of nodal conduction. What about HV? We know in presence of accessory pathway, HV interval become short, then maybe negative. And finally assess antegrade Wenckebach cycle length if it's nodal conduction. Wenckebach cycle length is the cycle length when 1-to-1 antegrade conduction stop. Normally it is between 350 to 450. Not only this, we can localize the level of AV block. Let's see an example. Incremental atrial burst pacing at 360 1-to-1 conduction, then 340 more incremental burst pacing one-to-one conduction AV, then we can appreciate after the 8th beat A without V. So we reached the Wenck-Bach cycle length. Let's go to final step, atrial extrastimulus pacing, golden rule. When we use the atrial extrastimulus pacing, we should know we can differentiate between nodal and extranodal. How? Assess presence of absence of pre-excited QRS complex. Number 2, decremental AV nodal conduction in case of AV node. Number 3, initiation of tachycardia, and this is the most important when we use atrial extrastimulus to differentiate, is it AV-NRT or accessory pathway mediated tachycardia. Finally, antegrade AV ERB and the atrial ERB. Okay, so let's start the rule of atrial extrastimulus in case of nodal conduction and induction of AV-NRT. As you know, start with in sinus rhythm, then atrial pacing. We can appreciate conduction of impulse through AV node and fast pathway, and the more incremental conduction or acceleration of heart rate, the more decrementation. Then what is called dual AV nodal physiology, and this concept is the cornerstone to understand the mechanism of AV-NRT initiation, in which there is a jump from the fast pathway to slow pathway and in the same time. Now let's go to this example of nodal conduction AV-NRT. What happened when we start? Okay, antegrade conduction. We will give atrial extrastimulus in nodal conduction. Start to give SC2 at coupling interval 370 and see the AH time. Yes, we can appreciate AH is long. It is conducted through the fast pathway. When we give SC2 at 370, we can measure AH interval 275. Let's give SC2 at short coupling interval of 360. We can see AH become prolonged 285. What happened? More decrementation, because fast pathway will decrement when we give SC2 at shorter coupling interval. It's a concept of nodal conduction. Now let's give SC2 at shorter coupling interval 350. What happened? AH jump. What does it mean? When the impulse tried to conduct through fast pathway, it was in refractory period, so it jumped from the fast pathway to the slow pathway, and AH decreased suddenly more than 50 milliseconds. What is called dual AV nodal physiology. Then the impulse go down to ventricular activation, and retrograde to atrium through the fast pathway, and the induction of short RB tachycardia, very short VA interval. We can appreciate short RB tachycardia, 1-to-1 conduction, VA time less than 70 milliseconds, and the retrograde A, which is called the echo beat. Now this is the typical AV-NRT, and we understand the concept. Now let's go to accessory pathway mediated tachycardia. Golden rule we have to appreciate when we give atrial extrastimulus in case of accessory pathway. And this accessory pathway has antegrade conduction. So in sinus rhythm there is pre-excitation. When we give atrial extrastimulus, we can appreciate short RB and short HV interval, and more evidence of ventricular pre-excitation, wide QRS complex. Let's give atrial extrastimulus at shorter coupling interval. What will happen? We will unmask the accessory pathway, shorter HV, then simultaneous HV activation, then become negative, then the accessory pathway, no more antegrade conduction, and initiation of what is called orthodromic reciprocating tachycardia, antegrade AV node, retrograde accessory pathway. Here we can appreciate when we give atrial excess stimulus or in normal sinus beat, we can see the accessory pathway has antegrade conduction. So pre-excited QRS complex, ventricular pre-excitation. What about HV interval? Become very short because of accessory pathway. Let's give atrial excess stimulus at shorter coupling interval. What happened? HV interval become very short, then simultaneous HV activation. Why? Because of accessory pathway. Then antegrade accessory pathway conduction, no more conduction. Why? We give atrial excess stimulus at very early coupling interval of 290. No more antegrade conduction. Through accessory pathway, initiation of orthodromic tachycardia, antegrade conduction AV node, retrograde conduction accessory pathway. What we can see? Short RB tachycardia, VA interval more than 70 milliseconds. And finally, this is the initiation of accessory pathway mediated tachycardia. Accessory pathway no longer conduction antegrade because of very early atrial excess stimulus. So it is in refractory period, so the impulse will go down through the AV node, then retrograde conduction through the accessory pathway, initiation of orthodromic accessory pathway mediated tachycardia. This is the summary of AB study. Thank you so much, dears. Wassalamu alaikum ورحمة الله.